to the pathology section for Falcon Physician Reviews. In this lecture, we're going to be specifically talking about ocular pathology. We'll try to include as many clinical examples as we can to help with your learning and get you your better scores on USMLE 1 and 2. Today we're going to discuss several features of ocular pathology, including congenital abnormalities, disorders of the conjunctiva and cornea, uvea, lens, retina, optic nerve, and even the lids. This is an overview slide. It's a simple cartoon which will help you get most of the information you need for ocular pathology. You'll notice here that we have an eyeball or a globe. In the front we have the cornea, and then the anterior chamber, which is bounded by the iris, and then the lens is suspended by suspensory ligaments which are attached to the ciliary body. The rest of the eye is composed of 3 consecutive tunics, or coats, the outermost being the thick white sclera, which gives people the white of their eyes. Just inside of that is the highly vascular choroid, which distributes blood to the innermost layer, which is the retina. The retina is a specialized nervous tissue which captures light and sends it as electronic signals into the brain through the optic nerve. There are different disease processes that can influence each and every one of these different segments of the eye. We'll go through the most clinically relevant sections together. Congenital ocular anomalies. Let's start out with a case. The case presentation is the NICU resident consults you for a kid whose eyes don't look right. What we have here is a picture of a young child with a congenitally cloudy cornea. We know that he's from the NICU, so he's newly born. If both of his eyes look like this, we have a problem. That's not normal. The cornea, which is normally transparent, is clouded over. We need to figure out why. The differential diagnosis for a congenital cloudy cornea for the non-ophthalmologist is congenital glaucoma. This is something when the pressure inside the eye is too high, and so the normal adaptive mechanisms of the cornea peter out, and it no longer is able to pump out liquid, and so it becomes edematous and cloudy. We want to look for a big eye or a big cornea to show us that they have other signs of increased pressure inside the eye. Birth trauma from forceps delivery can cause injury to the corneal tissue, which causes it to swell and become opacified. Metabolic disorders such as the mucopolysaccharidoses can cause congenitally clouded corneas, and those would be picked up on urine or blood samples. Finally, corneal dystrophies are inherent disorders of the cornea which cause it to be cloudy, and those are most likely going to be diagnosed by the ophthalmologist. When we look at congenital glaucoma, the etiology is often genetic. There's often a family history of glaucoma, and it's often secondary to structural abnormalities, which are defects in the trabecular outflow system. As you remember from your preclinical years, aqueous humor is made in the ciliary body, and it's transported through the anterior chamber, and it leads to the trabecular meshwork of the canal of Schlemm. In congenital glaucoma, these outflow pathways are diseased, and so the fluid cannot leave as efficiently. The pressure therefore builds up and causes the cornea to cloud over, and nerve damage, which causes vision loss. What you see then are large corneal diameters and cloudy corneas. You can't see the nerve because the cornea is cloudy and won't let you view inside the eye. The pathogenesis is chronically increased IOP, or interocular pressure, against a compliant newborn globe. The pathology, like I said, is a cloudy, enlarged cornea with cupped optic nerves behind. Signs and symptoms of congenital glaucoma are the classic triad of tearing, reflex blinking, or photophobia. The basic diagnosis is based on the cloudy cornea at birth and measurement of the interocular pressure. Treatment often involves surgery to lower the pressure and medication also to lower the pressure inside the eye. Here's a picture of congenital glaucoma, what it looks like in the optic nerve. On the left, we have a normal-looking optic nerve with a small cup, which is the pale center portion, and a larger disc, which is the larger pink area. With glaucoma, whether it's congenital glaucoma or not, you get a marked enlargement of the cup from death of the neural tissue inside the cup, which leads to an increase in the cup-to-disc ratio. You get a thin optic nerve rim in the disc, and that's a sign of glaucoma. Histologically, it looks as shown in this slide. On the left, you see a normal optic nerve with a small central cup and a large disc. On the left, you have large excavation from the death of glial cells and nerve cells, which leads to a large dramatic central cup and a small disc surrounding that cup. Next, we go to the conjunctiva and the cornea. The normal anatomy of the conjunctiva is a clear epithelial tissue which provides vessels which bring nourishment for the overlying sclera. It has glands and vessels which provide the secretions which keep the eye healthy. You can see here a histology of epithelial tissue with goblet cells inside. You've got non-keratinized epithelium. Underneath that, you have a loose substantia propria with some immune system cells and some vessels which provide nourishment. Here's the cornea. Normal anatomy, you have a normal transparent cornea overlying the iris and allowing light to pass through the visual axis. This provides the most refractive power for the eye, bends the light to help it focus on the back of the eye at the retina. You have an epithelial layer which is shown very small up on the top of this slide. 90% of the corneal thickness is the stroma volume itself, which is the bulk of the material of the cornea. And you have a thin endothelial layer which also has Descemet's membrane. Case number 2. A 35-year-old man comes to you with 2 days of a red eye and goopy discharge. You have a really pretty sick picture underneath which shows a goopy, red, swollen-looking eye. Nobody wants to have that. We don't think it's healthy. Must be sick. The short differential diagnosis for a red, goopy eye is conjunctivitis. You get irritation and inflammation of the conjunctiva. It has goblet cells and glands which secrete things, and it gets red and swollen and edematous. Keratitis is often unilateral with decreased vision and pain. It's more of a corneal issue that can also have inflammation in the localized conjunctiva around it. Scleritis is inflammation of the underlying sclera, and since the conjunctiva is clear, you can see increased inflammation from the enlarged blood vessels, and it'll show up as a red eye. Usually it's painful, and it doesn't have discharge. You should have a history of other autoimmune diseases such as rheumatoid arthritis, or Wegener's, or lupus. The etiology of conjunctivitis is often just infection or irritation of the conjunctiva, as we talked about, most often due to viral or bacterial infection. Morphology is dilated conjunctival vessels with exudation and edematous conjunctival tissue. The pathogenesis is present of local antigens and elicits a robust acute inflammatory reaction, which leads to the edema and the redness we talked about. Clinical pathology is the presence of acute inflammatory cells plus or minus bacteria on biopsies. We rarely do biopsies because most of this is transient and will go away all by itself. Signs and symptoms are a red goopy eye. The basic diagnosis is done by culture if you need to, but often it's a clinical diagnosis. Whether or not you decide it's bacterial or viral is kind of beyond the scope of this lecture. Treatments include antibiotics, cool compresses, and time. For epidemic cases and highly contagious cases, you might want to consider a quarantine. Here's a picture of normal conjunctiva on the left. Again, you've got a nice round pale goblet cell in the middle of a non-keratinized epithelial cell. You have a few inflammatory cells around there, but mostly it's okay, and you got a nice vessel. In pneumocystis conjunctivitis, you have a lot of inflammatory cells. It's degraded the overall tissue architecture, and there's a lot of exudate and inflammatory cells. It looks like inflamed tissue no matter where you see it. Thirdly, let's talk about the uveal tract. Case presentation number 3. A 14-year-old boy presents with pain, photophobia, or light sensitivity, decreased vision, and a red eye for the past 3 weeks. You get a picture like this. Anytime you see that white in the bottom of the pupil, you know it's not right. That is layering of white blood cells in the anterior chamber, and that's called a hypopia. You can see that the surrounding conjunctiva is also red and inflamed, so he must have something going on. We could think of conjunctivitis because it's a red eye, but he's got other things too, like pain, photophobia, decreased vision. So we have a differential diagnosis for a hypopian. We have uveitis, which is inflammation in the uveal tract. It's often associated with autoimmune conditions. We have infection inside the eye, inflammation from an infected cornea or of the whole eye, which is endophthalmitis. Also, we have retinoblastoma, which can look like a hypopian. Actually, it's what's called a pseudohypopian because the accumulating cells are tumor cells and not red blood cells. Uveitis is inflammation of the uveal tract, which is that middle layer coating the back of the eye. It's frequently idiopathic, which means we don't know why it happens. It's often, though, related to autoimmune disorders. You can get juvenile rheumatoid arthritis, sarcoidosis, HLA-B27 diseases, or you can get chronic granulomatous infections such as Lyme disease or syphilis or TB. Pathogenesis is localized inflammation of the uveal tract. It leads to accumulation of inflammatory cells and destruction of normal tissue planes within the eye. Other complications include retinitis, choroiditis, exudative retinal detachments, and other problems related to the chronic inflammation of the uveal tract. Uveitis clinically shows the presence of acute inflammatory cells and eosinophilic debris inside the anterior chamber. Signs and symptoms include pain, photophobia, decreased vision, and a hypopia and other signs of chronic intraocular inflammation. The basic diagnosis is based on physical exam. You also need, though, to do serologies and other tests to help if you can identify the autoimmune disorder associated. treatment often involves anti-inflammatory treatments, such as topical steroids, or even if you need to, steroids in or around the eye. Here's a picture of the normal uveal tract, including the anterior chamber iris and also the ciliary body as it proceeds backwards to turn into the choroid and choriocapillaris. You have a normal iris, which is heavily pigmented, and you've got some normal inflammatory cells there, nice tissue planes, good discrete organization. If you look in the bottom picture, you have a chronically inflamed iris, and all that purple, pink stained tissue are chronic inflammatory cells. You can see how it's a thickened structure. It doesn't have quite the same orientation as it did before. In addition, there's a small connection between the iris and the rest of the anterior chamber angle as it meets the sclera. That connection helps inhibit the outflow of aqueous humor and leads to increased pressure inside uveitis cases. Let's take a break. We'll finish with the rest of the ocular pathology in the next section.